Hi. So I'm really honored to be here with you today. My name's Amy, and we're going to talk about patient-reported outcomes in action. And what I'm hoping to do today is convey to you that as we think about the rise of the collection of patient stories within the context of clinical care and research, we can do lots of things with these data. And the more that we use them and make them relevant, the more the data are available and actionable, and the higher the quality of the information for the research that we're doing together. I have a lot of funding and disclosures. To suffice to say, I'm going to present to you a story of research today that represents information from coming from many different areas, but probably the main disclosure that I want to point out is I also own an IT development company. So we do a lot of technology development, as you'll see, but overall, the research that you're seeing here today is predominantly federally funded. I want to just make sure that we're all on the same page. We're going to talk today about patient-reported outcomes or patient-reported outcomes measures. Pros or proms, it doesn't really just matter what country you're in. We're really talking about the information that reflects the patient voice, symptoms, quality of life, whether or not you're taking your medication. My favorite, wee-wee, was it worth it? Medication compliance, value is measured in many different ways. And you know, as we start to talk about patient-reported outcomes, there's really the story of how we started to get here. I told some of this story earlier today. I was the principal investigator for a study called the Palliative Care Trial being conducted in Australia, which was a community-based palliative care trial looking at 3 different interventions in a 2x2x2 factorial design study. And what would happen is on 2 days of the week, I would go out with the nurses, and the nurse and I would see patients together, and we would ask patients about symptoms and record the information and diligently take care of patients. That was Tuesdays and Thursdays. And then Mondays, Wednesdays, and Fridays, I would diligently go to patients' homes, this time with the research nurse, and we would record patient symptoms on our clipboards, put it on the case report forms, and take it back and type it into our database. Same patients, same pain scores. Sometimes I would scratch my head about why the pain score on the Monday was a 5 and on a Tuesday was a 7, but I would actually ultimately think to myself, well, it's probably got to do with the patient and the treatments and their personal experience, and less about the difference of how we were collecting pain as doctors and nurses versus as researchers and research nurses. And so I started to think about how might we collect a central data system where we were able to manage our clinical tasks simultaneously with our research tasks. So understanding patient concerns, conducting the clinical care based on that, so responding to patients' pain and hopefully treating it appropriately, and then also using that information to monitor how good we were in practice, so monitor or audit our clinical care quality. Meanwhile, same information shouldn't go into the same database and be used now, survey information, being used to conduct clinical research. And ideally, if we create the right kinds of data systems, I don't have to go back and type it in. It should be collected electronically at the point of care in practice when appropriate and be able to go into the same data system. And so ultimately, that was the way that we started working on a series of solutions that have led to really an overall program focused on the role of patient-reported outcomes. Well, what a great opportunity. So one of the things I sat down and asked myself at that time, this is circa 2002, 2003, was like, well, if it makes so much sense, why is it that we're not doing it? Patient-reported outcomes have historically been really difficult to collect. Why is that? Well, part of it is that the patient voice was seen as subjective, not nearly as good as getting a blood pressure or having a person stand on a scale. Another reason was that the data were frequently missing, sometimes for patient reasons, sometimes for clinical reasons, sometimes we just didn't care about it enough to collect it very well. We had all kinds of issues around reliability and what scale to choose and blah, blah, blah. And ultimately, all of these things became barriers that got in the way. But I really started to understand better that there was also a series of other actions that were in the way. A lot of it around the fact that it was very hard and can still be very hard to practically collect patient-reported outcomes information or PROMs. Just doing it is hard. And often one group or the other is driving the bus. The researchers are saying we have to have this information, and so the researchers are out there driving the process, or the nurses and the doctors are saying we have to have this information, and they're driving the process. And if the doctors are driving the process or the nurses, the researchers say that data is not clean enough for me. And if the researchers are driving that process, the clinicians say that information is nonsense, that's not what I care about. And by the way, very few times is the patient and the caregiver driving the process. Completely upside down. And also, there was this problem of alignment of incentives. So nobody's incentives were lined up to allow the whole process and system to happen. So in fact, the research didn't understand what the clinical needs were, and the clinicians didn't understand what the research needs were, and very few people were asking the patients what their needs were. And so no wonder the systems weren't working. So trying to solve all that. So this is my beware slide. This is instead of being beware of the snakes and bears, at this point, the message is beware of what seems to be obviously in front of you. For the next 15 minutes or so, I'm going to tell you the story of what looks like patient-reported outcomes or PROMs sitting right in front of you in nice fancy reports and cute little computers. But really, this is going to be the story of data liquidity. It's the ability to move data from one place to another and use it simultaneously for multiple tasks. Of the need to have data that we can use right here and now, because right here and now means it's actionable. The ability to say that once we have banked data, we can use it for all kinds of other things that increases the value of the information that we've banked. That in order to do that, in order to have liquid data and be able to use and reuse it, we have to have some kind of standards. So I this morning got out my, because I just got off the plane, right? So I got out my UK plug, because now I understand the standard for plugging my computer here in the UK, and it was different than my American plug. And so similarly, we have to have standards of how we collect and use data in order to be able to have actionable information. And then it's also around culture and incentives, how we understand how to line up clinical care and research together and putting in a process of learning. Practicing, seeing what happens, updating the process, doing it again. And that really is the story I'm about to tell you. So a few years after the palliative care trial, I was standing in my clinic in Durham, North Carolina, and said, you know what? So if I really could have made my weeks much more efficient in Australia, I would have merged Mondays, Wednesdays, and Fridays with Tuesdays and Thursdays. And in order to do that and bridge the clinic and practitioners, we need to be able to collect data that the clinicians find valuable, and along with patients, and that also that the researchers see as of high enough quality that they find it valuable too. Now that means we got to do two things simultaneously. We need to raise the bar of how we expect of data quality, because as researchers, we cannot have dirty data, because we can't do good research and good analyses. And meanwhile, the researchers have to understand that clinically meaningful information has to meet a certain kind of expectation, or it's just nonsense in my hands. And so we really started thinking about this concept of research quality clinical data. How do we endeavor to create a system that does both simultaneously? I could spend, the next 2 hours talking about validation work and everything else, and frankly, it's just historically boring. So instead, I'm going to really show you what we learned, and then if you want, we can get under the hood further. And one of the things that we learned is that in order to create systems that get us to the point of collecting research quality data, we need to actually think about the overall ecosystem of what it takes to collect those kind of data. And then once we've collected it, we need to think about the ecosystem of what it takes to use those kinds of data. So I'll talk about both things. So on the side of collecting research quality clinical data, predominantly patient-reported outcomes, that's what we're talking about, although we can start applying this to all kinds of other processes, we need four things. We need a combination of software and hardware, the questions. In the case of patient-reported outcomes measures, we're usually talking about survey instruments, making sure that the data are usable and used in real time through reporting and analytics, and the mother of all of this is process. Ultimately, it's how we bake it into the process of care in the clinics, or how we do our home visits in palliative care, or how the overall system of delivery happens, and understanding that that makes the difference of whether or not data are collected or not. And that importantly, at any given time, ideally, we fix the questions that are being asked so that the same pain question is being asked whether you're in the clinic or you're doing a research study, and we all have a standard of whether or not we're using the POS or the �ERT-CQL-Q30 or the ESAS or some set of instruments that we understand, so that the instruments are relatively similar and we can speak across in a similar language, and then we can toggle or change around the software and hardware we choose. We can even use papers and pens. We can toggle around what kind of visualization, reporting, and analytics systems we use, and we can tailor the approach for every single different clinical scenario. It's absolutely fine. So as an example, a patient reports standardized information when they come into the clinic. That information is then fed into a set of coordinated databases, and then the data is in real time pulled out of those databases to be used for clinical uses at point of care. So it means that the information has to be something that doctors and patients want. We can use it for longitudinal reporting, clinical review of systems and documentation, patient education, and triggered interventions. And importantly, we've got to understand the overall care process well enough to know which of those are valued in the clinic, because if we try and force feed something, it doesn't work well and it just annoys everybody. And then meanwhile, from those coordinated databases that have been banking the information, we can then pull out the data that we need for a series of research and audit uses. So for example, quality reporting or auditing, clinical and comparative effectiveness research, and other hypothesis generating and experimental research activities. And then meanwhile, those same coordinated databases can start to port over our research uses to be able to be incorporated in clinical decision support and guidelines, so that ultimately we've got an overall system of learning, as well as information that's being collected and continuously reinvested in those overall systems of databases. So the databases in the middle are continuously getting better and bigger and smarter, and the system itself continues to feed. Well, that's the vision. Let's drill it down. So let me show you a little bit about how we sort of solving some of these problems within our clinics. Now remember, every one of those components, the questions that are asked, the hardware and software, the reporting analytics, and the process can be toggled and changed out depending on the clinical scenario. And I'm just going to show you how we were solving it in our own clinics, and then how we took these lessons and started to move them into other solutions. So for a long time, 2003 to 2005, 2009, this was often called the story of Amy and her e-tablets. Now, if you come to my office, I have what I call the electronic graveyard. So part of my story is that I'm cheap. And in being cheap, I'm not cheap in hotels, but in being cheap in electronics, I buy what's on bulk on eBay. So if it is old and on eBay, I will buy it and test it out. And then those things which I don't like, I dump into the computer graveyard in my office, and those things which I do like, I then go buy in bulk. And so that's basically the story of how we've gotten all kinds of different things. And so we started off for a long time with these old motion computing tablets. Why these ones? Well, because, by the way, we could buy them in bulk, and I could get essentially 1,000, or so, I think we bought 200 at one point in time. That's the most I ever bought in bulk, but 200 for something like about 80 bucks a piece. So I really was not paying a lot of money for hardware. We've also used iPads, we've used desktops, we've used electronic pens. We use these pens often for our elderly patients who we have tried little scan bubbles and optical mark readers and everything else, and the problem is that all of those things requires you to be able to see well enough to do scan bubbles and everything else, and these pens digitally pick up where they write on a piece of paper, and then ultimately we can send that back to a computer database. But the overall approach is location and platform agnostic. It means that really when you get right down to it, you could pull anything out of my graveyard and use it. The only reason it made it into the graveyard was because it was bulky, ugly, patients didn't like it, it was too heavy in their lap, or it got hot on the bottom. And believe it or not, we've asked them all of those questions. And the hot on the bottom is one of the things that ultimately drives a lot of this. So then what we did was we started looking at what kinds of questions did we need to ask people. So I flew all over the US. I'd actually been here in the UK looking at some systems. I was in Australia, looked at back and spine clinics, pain clinics, oncology clinics, and tried to understand when people were collecting patient-reported outcomes instruments in the clinic, clinically, when doctors wanted that information and valued it, what did that look like and why? And when was it that it was working and the researchers wanted to use it too? And when was it working and the researchers put their nose up and said, no, 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 I don't like that stuff? And what was that all about? I learned a few things. So first of all, after looking at a lot of different systems, I realized that doctors and patients and nurses liked the systems when it solved the problem of the clinical review of systems. So for those of you who don't know what a clinical review of systems is, as a part of a routine clinical interface or encounter with a patient, first we ask the question of what it is that brought you here today or what's making you feel bad. And then the second thing we do is essentially a checklist of making sure that we didn't forget anything. Making sure that they not have any problems with urination, making sure that they're not having any problems with their bowels, making sure that they don't have any headaches. So it's essentially a checklist, and that checklist shifts around and changes depending on the scenario. We then get our laboratory tests, maybe some other past medical history of as needed medications, all that other stuff. We develop an interpretation and we go about our merry way of making a plan. But fundamentally, that checklist of all the questions that you need to ask is called a clinical review of systems. And what we learned was that when doctors were valuing the system, it was because it was supporting their need to do a clinical review of systems quickly and to document that information. And ideally, document it longitudinally over time. We also noticed that the clinics that wanted the systems valued efficiency. Anything that made them slower or got in the way, they threw out very, very quickly. So that the systems had to make them feel more efficient and more valued in what they did, or they actually didn't want them. We can come back to that too. Meanwhile, when we looked at what the researchers wanted, they wanted that the instruments had been validated and that they could find documentation in the research literature that the questions that were being asked had research merit. And so when we ultimately looked at a whole bunch of different places, one of the systems that seemed to be working well was the patient care monitor solution being used by about 25 community oncology practices in the United States that were extending from Montana to Miami. And these community oncology practices were all using the same PRO solution, this case the patient care monitor, asking exactly the same questions, sometimes with different computer interfaces, but then ultimately using it the same way in their practices. What then happened? Now you had 25 practices across the country all collecting the same data. As a researcher, I saw the value in that really, really quickly. So then we realized that if we had something that clinicians wanted, we could now embed other instruments and do what I call drag them along. So if I needed, for example, the FACT melanoma, because I'm a melanoma researcher as part of my time, and I need to do a quality of life scale for people with melanoma, I can combine the clinical review of systems instrument that those community oncologists wanted with the FACT melanoma instrument and get both, but the clinicians were not going to give a FACT melanoma instrument instead of their clinical review of systems instrument because they needed the clinical review of systems instrument for their practice. And electronically, I could designate which patients get what. So it got to the point, and still is, this is a little picker screen, like you can choose checkbox, that if Joe comes into my melanoma clinic, and Joe is just one of my routine patients, not on any clinical trials, each time Joe comes in, he gets a clinical review of systems called the patient care monitor. Sally, she comes next after Joe, and she happens to be on one of our melanoma trials, and that trial needs a quality of life instrument every 3 months. So electronically, she gets her clinical review of systems every time she comes in, and once every 3 months, the system sends out the 3-month quality of life instrument as designated within the system. Meanwhile, Charlie has been getting sicker, and he's got metastatic melanoma, and he's starting to develop really bad pulmonary mets, and he's having some problems with shortness of breath, and we're putting him on one of our morphine trials for dyspnea. And so as a result, he gets the clinical review of systems plus a drill down survey about dyspnea in order to better understand the impact of dysmenorrhea on his life as well as his wife. So at each visit, we can designate differently what happens. But importantly, the research instruments were brought along by the clinical side, not the research side bringing along the clinicians. Then, the other part of this is to reinforce this system through clinical uses. So the doctors use it for clinical review of systems and decision making. Importantly, when we develop these systems, we teach the clinics that, you know what, this grouping of information really is definitely needed by the social workers and psychologists. We don't even have the doctors and nurses look at that information unless they want to, or the social workers and psychologists say, by the way, you need to look at that. Because what that does is reduce the knowledge burden of both groups. Everybody is happier, and by the way, the patient gets the total book of care that they needed. In order to do that, we need a series of reporting tools and analytic tools to make this happen in real time. Now, you can't read anything on this, and that's actually the point. This is currently the report we're using. We're in the process of upgrading our reports, but there's some important things about this report. So the first thing is, I submit to you, in case you're developing patient-reported outcomes measures solutions, doctors don't like graphs. I know that's different than what everybody likes to do, which is give every doctor a longitudinal graph, and that's because it's really cool that we can do that, right? But in fact, one of the pancreatic cancer doctors with whom I work made a really good point. She says, you know, Amy, well, the problem is they have the graph for the pain up there and the graph for the constipation over here, and I can't make a decision about how to treat her pain until I know what's going on with her constipation. So in my mind, I have to pull the two graphs together, superimpose them, and try and decide whether or not she's constipated so I can decide what to do about her treatment of her pain with morphine. Because clinically, that information belongs together. So doctors are pattern recognition people that need to understand how all of the information interrelates as opposed to information disconnected over time. And so the way that we present reports becomes really, really important because it's the way that information becomes actionable right now. So this report here is the one used by those community oncology clinics. It actually has 4 different time points. It reflects the actual numbered score. In yellow as if the scores are between 4 and 7. In red as if it's 8 or above. And there's all kinds of colors here. But basically, it's the pattern of what is different colors that those doctors needed to know. Colors down here indicate the patient is having a hard time getting out of bed. So this means that this patient probably has a pretty low palliative performance score, or 𝐂𝐈𝐂𝐂𝐄𝐋 score. Colors in this section here indicate the patient has a high level of distress or despair. Colors over here mean the person's having problems with rashes and other skin problems. You get my point. They know really quickly how to drill down and what they're going to do next. Meanwhile, for other parts of the care team, other pieces of information there. So these are normalized scores that get embedded in the report that provide a summary total of distress and despair, because this is actionable information that our psychologists need to decide whether or not this person needs more psychological intervention in the clinic. This area here is right now being amalgamated into a 𝐂𝐈𝐂𝐂𝐄𝐋 score, and we're in the process of doing that. So one of the things we learned was we had to make sure reports were actionable now and don't give people the information that they don't want to have. High-level reports with color coding is what most people want, and then they can drill down when they need it. Meanwhile, we asked patients, what do you want? And patients were really clear. And let me tell you, like, they didn't like the things that were hot in their lap. Things couldn't be too heavy. But when you really got down to it, there are 2 things that drove patients whether or not they were willing to answer all the different kinds of survey questions we asked them. Now, these are American patients coming to a set of community oncology clinics in the southern U.S., moderately educated, moderately to well-educated, about 25% non-Caucasian. But what did they tell us? They said, I don't care how many questions you ask me. I'll answer as many questions as you want when I come in the clinic. Ideally, somewhere between 10 and 15 minutes is about how long I'm willing to ask questions, but it's really mostly got to do with how long I'm sitting in the waiting room. If I'm going to answer them at home, it's about the same amount of time. I might, have a little bit more time if I'm doing it at home. But I need 2 things from you. First, the doctor or nurse needs to endorse the fact that they saw my information and appreciated the information. So we have to teach the doctors and nurses in the clinic to say, I saw your report and here's what I noticed. That one sentence reinforces in the overall system that the data were important. And the other was, if I tell you that I'm having problems with sleep, don't teach me about constipation. Teach me about sleep. So match the education to who I am and do so at the time I need it. One of the things we learned in our chemotherapy teaching is teaching people when they're just receiving their chemotherapy how to manage a problem that may happen 30 days from now is kind of nonsense. So why not figure out how to queue up that information when they need it, or teach them how to get there and their caregivers how to get there when it is that they need it, and make sure it's available to them. Meanwhile, in the clinic, the nurses said to us, you know what, once we've had to do something 3 to 5 times, stop making us do it all the time and write some computer code to solve that problem for me. So one of the things that we realized on the back of that report, whoops, right here, was every single time a patient had a 65 or above on these scores, I'm not going to get into the scores right now, every time the nurses and the doctors automatically called the psychologists. So Amy, tap some computer code and call the psychologists for me. Don't make me look at the score, make that decision, and call the psychologist, because I'm going to do it anyway. Now give me an out clause. So perhaps send me a signal that says I'm calling the psychologist. Let me know if that's a bad idea. Or let me call the psychologist as an additional thing. But you know what? Anytime we're going to do something over and over again, automate it. And so one of the things we automate is distress triage. And here's what happened. So here's the beginning. This is August 2009. We first started putting systems into the clinics. And what you see here is, there's some uptick. And basically, this is a diffusion of innovations model, right? So if you think about diffusion of innovations, people who are early adopters are the people who really think this stuff is cool, and also usually they're your friends, right? So find your friends in the clinic. Often these are your champions, but really they're the guy that you can walk to down the hall and say, does this work for you, or what should I change about it? They're the ones who are willing to be a little bit annoyed while you're trying to figure out what's heavy and hot in the lap and all that good stuff. And so you can see here we were working with our friends trying to get all the kinks out. And then over time, we now start moving from clinic to clinic. We go from the prostate cancer clinic now to the lung cancer clinic. And you can see as we hit each clinic, one of the important points about this is you don't see that the use falls off, because we were constantly monitoring when people were using the system, and if they stopped using it for any reason, within 24 hours, I was in the clinic saying, so I noticed yesterday you weren't using the system. Any problems I need to know about? What can I do to help? Because our job is to be there right away, to be able to figure out how to help right away. And meanwhile, we were monitoring in the background signals that were important on the research side. So remember, clinicians, doctors and nurses and patients, they're going to know right now if this information is useful to me, and the signal for whether or not it's useful is how I use it right now. For researchers, the problem is whether or not the data is of high enough quality that I can use it for research. So what are the signals of data quality we might monitor? It turns out data completeness, also known as missing data, is a really, really reliable signal. So we started watching across our clinics for when data started to basically become complete, and what did that take? And here what you see is that basically if we look across for any individual patient, the number of visits versus the cumulative proportion of patients for which we've got missing data, what we see is that at least a couple of items, 1 or 2 questions might be missing in the very beginning. There are a few, about 10% total missing questionnaires on the first visit. So it means about 10% of people don't have any questionnaires on their first visit. And we find that those are almost all people who are coming for second opinions. And then by the time they hit their 4th visit, the chance that there's missing data is less than 3%. Because their doctors have reinforced, I looked at your report, the patients have realized this is directly attached to my education, and the whole system has said to the patient, this was helpful to me, thank you very much. And meanwhile, the doctors are getting information that they need, and the patients are getting information that they need. Meanwhile, we shouldn't stop. So we're right now in the middle of trying to figure out how do we present more compelling and useful reports that send the kind of information to clinic administrators and other groups about what they need. And so this is an example of a heat map of data missingness that we're looking at right now as a way of monitoring data quality. And we need to constantly test what works and what doesn't work. And so we constantly test usability and feasibility, so essentially some of the technological features of the system. We also collect the reliability and the validity of the data, making sure that we can use it for a variety of purposes. And then what happens is we develop what I call the river of data, a continuously flowing river of patient-reported outcomes data we can now use for all kinds of different things. One thing I wanted to mention here before we went on was to understand the role of prototyping. So I find that lots of people call me on the phone to basically say, I want to know what computers you use. I want to know what software you use. And every time I go, I don't know, so tell me a little bit about what you need and everything else. And then they say, well, but I need to buy blah, blah, blah. I say, no, you know what, you need to develop something that looks like it's going to work and test it and keep planning to update it. And so we actually really spend almost all of our time in beta phase. Like, we rarely have finalized software for anything, because ultimately we always are finding things we need to update and improve on. And it's a learning cycle, not a fixed off-the-shelf buying Microsoft Word at the end of the day. And so ultimately, for the systems that we developed for our clinics, we combined hardware and software with the use of the patient care monitor plus other surveys, real-time reporting and analytics like a report like this, and embedding in process, and then monitored missing data as a way of ultimately getting to the point of having research quality data. And now that we're there, we can do a lot of stuff with it. So I'm going to just show you for a few minutes about what we can do with it. So one of the things people often ask me about is whether or not these data are in our electronic health record. They're sort of in our electronic health record. They sit alongside the record, and then reports can be used by the doctors and go in as PDFs. They look almost like an EKG would look, right? So people I always say to people, well, so is the EKG in the electronic health record? And they say, well, yeah. I said, is it individual data? Well, I don't know. I said, the truth is there are individual EKG data, but it's somewhere in a database that you rarely get to. And similarly, we have all of these data sitting in big data warehouses that we match and merge with the clinical administrative data, the clinical trials data, as well as molecular data. And we can use this for a variety of purposes. So in terms of then what do we use it for, here's 3 examples. Same patient data. At the individual level, we're using it in the clinic like you saw. We're now writing a series of research reports, all kinds of different things that I can show you about. And meanwhile, our administrators use it to make clinical decisions and administrative decisions. So this particular example, I was sitting with the vice chancellor of the health system, and he said to me, we're trying to decide whether or not we need more pain doctors for the cancer center. Can you tell me if you know anything about what the pain experience is like in the cancer center? And I said to him, 21% of our patients have pain scores of greater than or equal to 4 out of 10 on 2 or more visits in 5 minutes. That was actionable data now to decide what we needed to do in terms of hiring more pain physicians. Meanwhile, on the research front, this is probably the most in-your-face research example that we've got. Beware of finding things that you didn't necessarily want to find. And this one is that we discovered is that sexual distress is one of the top 5 concerns in our oncology clinics, as well as in our palliative care patients. Not something we often ask. So first thing you know, we're start doing all of these studies documenting the prevalence of sexual distress. Scratching our heads, we could basically say people who had breathlessness had sexual distress, people who had poor quality of life had correlations out the wazoo. That was all kind of entertaining, but what do you do about it? So then, first thing we did was we tried to rearrange all the patient education. So we made sure all the pamphlets on the wall were easy to get to. They were, sensitive, and the nurses and the doctors kind of had some kind of language to talk about. So I hear you're having this problem. Let me give you this booklet. That didn't work. We could monitor what was happening in sexual distress. It was still one of the top 5 problems. And interestingly, it was a problem that was flat. Like if a person had 8 out of 10 sexual distress, it was that way every single time. So we got a meeting together kind of like this and had all kinds of disciplines there. And really, it was the psychologists who were most helpful. And they said, this is probably an intimacy problem. We need to know more about that. So we sort of did a little deep dive in terms of reports of sexual distress and intimacy. It wasn't a function problem. It was an intimacy problem. So then we developed a flexible coping model, which was published in Support of Care in Cancer pretty much immediately. And then we went to the American Cancer Society and we said, we know we've got a problem, we've got a model. We can electronically randomize patients between one intervention versus the next. Would you fund a trial looking at the flexible coping model versus no intervention for people in our system? And they funded the trial, and the electronic system does the monitoring. So the electronic system finds the patients, and the electronic system monitors outcomes. Guess how long it took from our first paper, which said we could ask patients tough questions using our little computers, to our funded trial? 18 months. Because suddenly the acceleration of research is remarkable when the data are already there and analyzable. This is another example. So this is a psychosocial model called Pathfinders. And now we have a river of data. And we want to know if we introduce a new psychosocial care program into the clinic, does it seem to make a difference? Now, ideally, we'd have a randomized trial, but I'd submit to you, we're kind of getting to the point where randomized trials for everything is both expensive and becomes somewhat nonsense. Instead, what if we use our river of data, introduce our psychosocial care program, and now monitor those patients? We should consent them and get all the right kind of data and consent and research pieces in place. And then what if we add in extra research surveys at very, very targeted time points to look at whether or not people who seem to be responding to the intervention have any changes in the kinds of things the intervention is supposed to be doing. So the intervention, for example, is supposed to support spirituality. So what if we look at a spirituality scale? It's supposed to support optimism. Let's look at what's happening in optimism. It's supposed to support psychosocial support, social support. So what happens in social support? So if a person has improvement in distress, is it because we've seen with this program changes in spirituality, optimism, social support? And in fact, what we saw was that spirituality and optimism went up, social support didn't change, and coping didn't change. So we now start to see essentially some mediation models that we can use within the same system, not collecting any more data than we ultimately started with. And then we now have essentially in our clinics scorecards that doctors and nurses can start to look at that incorporate now patient-reported outcomes as opposed to the typical scorecards that just look at whether or not we collected enough lymph nodes and whether or not people waited in the waiting area. So we now look at things like fatigue management and pain management within our clinics. So in the next 5 minutes, and I think that we'll be right on time to end, I'd like to do is tell you a little bit about taking the technology to the next level. But beware, just like before, don't be enamored with the technology. Really, this is about process. So the first is something called 𝐂𝐂𝐂𝐃. So in this particular example, the palliative care doctor said to us, what we want is we want something at point of care that collects the information that we need to know how well we're taking care of our patients. And by the way, it should be filling a database on the back end that we can use for research. And so what we did was we worked with them to create a system that did that, and I can talk more about that, but I don't really want to focus on that right now. What I want to focus on is it was this partnership between the doctors and the nurses coming on the phone call every 2 weeks to say, here's what we need, here's how here's what we'd like to see, and an IT team and researchers as a part of the phone call as well to ultimately create a system that the doctors and nurses wanted to use and where the database that was being filled, including with patient-reported outcomes, were of adequate quality to use for research. And so what they told us was we want a clinical interface that needs to interact with our electronic health records. Colors need to change in real time. I don't want a whole bunch of annoying, bells and whistles. I just want to see some color changes on the left-hand side to tell me when I need to modify my practice. I'd like to be able to quickly navigate and find the areas of concern like insomnia management or better management of constipation. And I want to be able to do that in a way that meets my expectations of palliative care practice. So give me all of the different domains of palliative care, including advanced care planning and spirituality. And meanwhile, on the research side, we wanted to make sure that we did all of the right human factors research and usability and feasibility testing and validation testing, that we could trust the data that was coming out for research purposes. And the doctors wanted reports that were simple and easy that said, you're doing a good job, or you better kind of change in these particular areas. And for whatever reason, they love these little check boxes. So we gave more and more check boxes over time. And ultimately what we've gotten to now is essentially an overarching system that's being used at point of care whereby doctors, nurses, researchers, and patients are coming together within the context of one solution and the data sets enlarging. If we want to add some sophistication, we add in visualization tools. This is a heat map. This just happens to be an example I use all the time. It's the map of the markets. It has nothing to do with anything else besides the fact that it is really cool applet. We use customizable reports. These are the reports that are right now being used in the 𝐂𝐂𝐔𝐍𝐃𝐄 system, so the kind of reports that the doctors are getting in the palliative care clinic. These are the reports the oncologists like, so these are the ones we give to the oncologists so they can see what data they got over time. And we're starting to develop all kinds of other interfaces, ultimately possible because we have this sequentially linked data in the background. Again, it really is all about data flow and liquidity. What are the lessons we've learned? Well, the first is that there are 4 interchangeable components, like I said. That the user interface and the reporting are critical, and all of this has to be baked into process. We have to meet clinician and patient needs first. And I can't say that enough. Really, this is a research with service model, but it works both for clinicians, patients, as well as for researchers. And that we can use very efficient approaches to understand data quality and make sure that the work is available for research. So visualization of our data, watching for where missing data are, and trying to fix that as quickly as possible. It does mean that you need a team of people available to you that are often not part of the research environment. Informaticians and computer scientists are your friends. Data architects, software engineers, statisticians and clinicians. I really think behavioral medicine should be at the table because I really think the understanding of what happens in the behavioral space is critical to how we make this stuff work, and clinical trialists. But ultimately, we need to do this in service of the clinic, and the whole team has to be working together. So in fact, for our data architects and software engineers, I actually walk them through clinical scenarios almost every 2 weeks because they have to feel in touch with what the issues are, or it's really easy to become out of touch. And then really to keep in mind that the story is really around data generation, use, and reuse in service of the people that we're trying to serve. So with that, I'll take questions. Thanks.